Hello, my name is Simon Khan, and today I'll be presenting my final project for GENED 1079, Why is there no cure for health? My project is titled RankRx, an automated drug ranking engine. Let's get into it. So first off, let's look at the problem. So one of the biggest problems that I noticed when I was looking through different healthcare problems in my research was that healthcare's current one-size-fits-all model is broken. The way that healthcare works at the moment is a group of patients are treated with the same therapy. So in this case, we have cancer patients with colon cancer. They're all given the same therapy. Some patients get a positive effect, some patients get no effect, and some patients even have adverse effects to the treatment. So there's a number of reasons why this doesn't work and isn't in the best interest of everyone at the moment. Primarily, it doesn't give a positive effect to everyone and can really lower the standard of care for the people that have no effect or have adverse effects. There's some data to back this up. Here's just some information from a national survey that was collected. Essentially, more than 35% of patients for which a classified drug is ineffective are listed here. So for 35% of patients, antidepressants are ineffective. For 40% of patients, asthma drugs are ineffective, et cetera, moving down the list. So this shows that there's a pretty big problem with drugs not being the most effective for patients. And that's the problem that I want to tackle. Oftentimes in healthcare settings, doctors don't have a robust way of prescribing the best treatment possible for a particular patient. A lot of times their decisions are experience driven and driven by anecdotal experiences that they've had throughout the years. This is kind of a problem because junior doctors are responsible for 91% of prescribing errors, and that is essentially just a statistical confirmation of the experience-driven mindset that goes into prescriptions. And the most important thing that I noticed was that genetics and epigenetics are often not considered when it comes to prescriptions that are given out by healthcare providers and doctors. 70% of medication errors that result in adverse effects are prescription errors. So if we're able to kind of crack down on prescription errors and ameliorate that error, then that can definitely help solve some of these issues that we see. So there's an increase in healthcare costs, which costs almost an additional $21 billion annually because of prescription errors. It worsens patient health outcomes because if they have adverse effects or adverse reactions, then they have to go get treated for other conditions. And it corrodes the integrity and trust that people have in medical practices in general. So the solution, and this is specific for Brigham Women's Hospital, but the general framework is applicable to the larger healthcare and hospital infrastructure that we have in the United States. So the crux of my solution is a biomarker-driven drug effectiveness ranking. So the idea is you input a patient's genome and their epigenome, so their RNA transcription and just more additional information about their genetic factors. And what this algorithm will do is it will output a ranking of drugs that are best suited to treat a particular disease for this particular patient. So the main problem is that there's a lot of drugs out there that can treat a particular condition, but we're not exactly sure which one is the best one for this particular patient. In the past, doctors would rely on their past experiences or just their anecdotal medical knowledge to pick out a particular drug or particular compound to prescribe. But oftentimes the genetics and epigenetics can really tell you whether or not a particular drug or a particular compound is most effective for a particular patient. So the key part of this is to create this algorithm that will rank the drugs based on a patient's genetic and epigenetic information. So this algorithm will be integrated into patient charts. So this is a really key component, especially at Brigham Women's Hospital. It's easy, so that way it's easily accessible and actionable by patient physicians and healthcare providers. They can easily see, given a patient's information, which drugs would be most suitable for treating a particular condition. And it ensures greater consistency of prescriptions across all experience levels of doctors. So that reduces prescription error amongst junior doctors because no longer is it this entirely experience driven. They have an empirical way of measuring whether or not a particular drug is a better candidate. And the most important thing, this is entirely opt-in because participation is contingent on participating in genome sequencing. So this is the general pipeline that I put together that sort of summarizes the whole workflow and the process by which this algorithm will work. So first, the first step is to do genome sequencing, collect patient genomic data using next generation DNA RNA sequencing, specifically for Brigham Women's Hospital. This is how we would do it. The way that we would do it is through their preventative genomics clinic, which was just opened as a way to make genome sequencing accessible to patients. So that's the first step. Once we have the genome of the patient and their epigenome, then we identify protein biomarkers using information that we gathered from literature, and also by analyzing the RNA expression between this patient and the mean in the population. And so when doing that, what we'll discover is that there are some proteins that are highly overregulated or underregulated, and those will be our protein targets for this particular condition. So once we have our protein target, then we're going to model the structure of that protein using homology modeling and a de novo protein folding algorithm, which essentially just creates a 3D model of the protein. And for biomarker identification, we'll be using the one example of a tool that's available out there is NCBI GO2R, and the Swiss model is available for protein modeling. So after that, the next step is to identify the binding pocket on the protein. And the way that we do that is through topological and biochemical analysis of the surface patches and cavities that are on the surface. And split pocket is an algorithm out there that is currently doing this sort of computation. And then we will computationally simulate the protein drug interactions through drug docking. And that essentially tests the drug fit in the protein binding pocket that we previously identified. After that, there will be a toxicity analysis and ranking, and predictive toxicity testing is computational. And then we would rank the compounds based on their structural fit as calculated in the docking step and their toxicity. And the ProTox2 is a server that currently does that. So the idea is these are all discrete elements right now that are existing in the current market, but now it's time to put this all together into a cohesive pipeline so that we can go from a genome sequence to a ranking of drugs that are best suited for a particular patient. So now let's get into the cost and funding. So the way that we're going to look at this is a software solution. So the crux of the costs come from the end-to-end healthcare cloud computing that we have. And after doing some digging and looking into the numbers, it costs just about $300 per server per month for the data needs that we have. For Brigham Women's specifically, 20 servers is the recommendation based on their size and the scope of this project, and which this all leads out to a cost of about $72,000 per year to implement the solution from a software point of view. And the bigger question is, why spend the money? So medical error is the third leading cause of death, and prescription error is a big part of that. This dispels distrust in the healthcare system, so we were able to greater reach out to underserved populations and populations that have historically been alienated by the healthcare system, and billions of dollars will be saved. Medicare Part D expenditure, which is prescription drugs, is projected to reach $165.1 billion by 2022. And as described before in this presentation, there's an incredible amount of waste that is financial waste that is generated in that spending. So by reducing that number, it will be a great win for the US healthcare spending budget. So the limitations, there's a few quick limitations that I want to go through. Genomic sequencing is required, so patients may not be 100% willing to participate due to lack of education about it or just personal reasons, which is entirely valid. And this ranking is also computational, so it can't be taken as the end-all be-all and does not necessarily reflect biological reality. So to mitigate some of these, in terms of lack of education, we need to increase genomics education to ensure that patients understand the full benefits and risks that are at play. And when it comes to the computational ranking, it's really important to emphasize that this must be taken in conjunction with medical expertise. So the anecdotal, like experience-driven mindset and paradigm that's sort of been driving prescription writing over the past couple of years, over the past couple of decades, that still needs to be there in conjunction with this more empirical way of evaluating drug fit for a particular patient. In the end, the goal is to eventually have this as a tool that doctors can rely on, and it will increase consistency in prescriptions overall. So I'm really looking forward to where this future goes, and I hope that you as the policymakers will eventually consider this a good idea worth investing in. Thank you for your time.